Let's summarize and discuss Meniere's disease versus otosclerosis in a single notes. Since these two are very important for the examination and both are having a single chapter, individual chapter in the ENT books, so it becomes very difficult during the examination to read about these Meniere's and otosclerosis separately. Rather, we in this uh, video will discuss the differences, key differences between otosclerosis and Meniere's disease, so that whenever the exam question comes on individual otosclerosis and Meniere's disease, you can write the same thing. So let's start with the Meniere's disease and otosclerosis. Synonyms: how the Meniere's disease is called. It is also called as the endolymphatic hydrops. Endolymphatic hydrops, a disorder of the inner ear where the endolymphatic system is distended. Endolymphatic system is distended with endolymph. But otosclerosis is a primary disease of the bony labyrinth where spongy bone replaces normally dense enchondral layer of the otic capsule. So we'll do like this, okay? Meniere's disease we'll first discuss, then after that we'll discuss otosclerosis. So Meniere's disease is endolymphatic hydrops. Pathology: a distension of endolymphatic system, endolymphatic hydrops, due to the increase in the volume of endolymph leads to the bulging and possible rupture of Reisner's membrane. The age of onset is 35 to 60 years. Meniere's disease, since it affects males commonly. How do you remember Meniere's disease? Men, okay? Men means males. Males, sir means 60 years, okay? It is unilateral. Males are always unilateral, they are not bilateral. These are unilateral, okay? Laterality is unilateral. Causes: defective absorption of endolymphatic sac, vasomotor disturbance, allergy, sodium or water retention, viral cause can be there, autoimmune factors can be there. Hearing loss type: it is sensorineural hearing loss, typically fluctuating and progressive. Sensorineural hearing loss, typically progressive, okay? Sensorineural hearing loss, unilateral. Males, men's disease, Meniere's disease, sensorineural hearing loss. Because males are sensitive, not sensitive, they have lost the senses. Males are always insensitive, right? Females are sensitive. So males have lost the sensation, sensitivity. So that's why sensorineural hearing loss, unilateral. Males is most common, that is Meniere's disease. Defective absorption of the endolymphatic sac, vasomotor disturbance, allergy, or sodium water retention, autoimmune factors. So cardinal symptoms are episodic vertigo, fluctuating hearing loss, tinnitus, sense of oral fullness. So in this, vertigo will be there. So vertigo will be there. So men's will always be roaming, right? Roaming people. So that way you can remember. So till now what we have discussed, we'll just write, okay? Meniere's means Meniere's. I'll call it as a Meniere's disease. Men means males. Yes, for you can remember sensorineural hearing loss, as well as 60 years. Males are insensitive, so that's why they have lost the sensation. That's why sensorineural hearing loss. Since men are walking around, traveling a lot, so they will be having vertigo, they will be going everywhere. Males are always unilateral, they are not bilateral, they can't do multiple things, so they are unilateral always. So this is what we have discussed till now. Let's move forward. Diplacosis, that is distortion of sound pitch. Diplacosis will be there. Intolerance to sound, loud sound due to the recruitment phenomena. recruitment phenomena. Since, how do you remember, males are roaming a lot, then that's why companies want to recruit them. They want to recruit men. I'm not talking about present situation. In the past, in the freedom fighting era, industrial revolution, there were only male workers, so they were recruited by the companies. So that way you can remember recruitment phenomenon. Diplacusis, distortion of sound pitches. Next, vertigo is present, episodic sudden attacks with nausea and vomiting, cardinal symptom. Low pitched roaring type, aggravated during the acute attacks. You can remember male as roarer. They will roar, roaring. Low pitched roaring type. Tympanic membrane appears normal tympanic membrane. Rinne test is positive. Weber test lateralized towards the better ear. Rinne's test is positive. So always these people are there, no? They don't take a lot of stress on them. So men are like, they are very positive people. So Rinne positive. Rising curve in early stages and later becomes flat. So men's career is like rising, always rising. Whenever they get old, as they get older, they start rising in value, they start rising in their responsibilities. So by this you can remember rising curve. Recruitment positive, as we have discussed before. Glycerol test is positive since men are positive people. Tullio phenomenon, where loud sounds produce vertigo due to a distended saccule, that is Tullio phenomenon. Lermoy's syndrome, where reverse order of symptoms, hearing deteriorates followed by attack of vertigo which recovers hearing. So there is vertigo, after that there is hearing loss, then after that recovery of hearing occurs. So this is Lermoy's syndrome. Tumarkin autolytic crisis, sudden drop attacks. So Tullio, Lermoy's and Tumarkin's autolytic. One more time. Let's repeat with me, okay? Repeat with me. Tullio, Lermoy's, Tumarkin. Tullio, Lermoy's, Tumarkin. Tullio, Lermoy's, Tumarkin. Come on, one more time. Tullio, Lermoy's, Tullio, Lermoy's, Tumarkin. Tullio, Lermoy's, Tumarkin. Tullio, Lermoy's, Tumarkin. So these are the unique signs. Low salt diet management, how do you manage? You will give diuretics because there is a lot of fluid endolymph filled, and because of that there is a distension. So that's why low salt diet, diuretics, vestibular sedatives like prochlorperazine, and vasodilators like beta histine. Management surgically, how do you manage? Endolymphatic sac decompression, that is shunt, since there is a lot of fluid, right? Endolymphatic fluid that is distending the endolymphatic sac. That's why if you decompress or put a shunt here, so that is endolymphatic sac decompression or shunt. Vestibular nerve section and labyrinthectomy. So that is about Meniere's disease. So just we'll quickly brush up. So Meniere's means men are positive, so Rinne's positive, glycerol positive. Men means males are more commonly affected. Males, yes, for sensory neural hearing loss. These are not sensitive people, insensitive people. Males are insensitive, so that's why they lost sensory, that's why sensory neural hearing loss. Since they have lost sensory neural hearing loss, they will roar and they roam a lot, so that's why they will go to vertigo. Because they are roaming a lot, they will be recruited by the companies. So median age is 60 years, 30 to 60 years. Now coming to the autosclerosis, opposite to this is autosclerosis. So let's discuss about autosclerosis, also called as autospongiosis. One more time, autospongiosis, a primary disease of a bony labyrinth where spongy bone replaces normally dense enchondral layer of otic capsule. A primary disease of a bony labyrinth where spongy bone replaces normally dense enchondral layer of otic capsule. Before there was a dense otic capsule that was replaced by, now it has become like a spongy. Okay, spongy. Before it was like otic capsule, dense enchondral layer was there, that is replaced now by this bony spongy bone. Okay, replacement of normal dense enchondral bone by foci of irregularly laid spongy bone often involves stapes fixation. Because of this spongy labyrinth, there is a fixation of otic stapes gets fixed. That's why stapes fixation at the oval window causing the conductive deafness. Suppose this is ear and this is external auditory canal, this is tympanic membrane, there is stapes here. This is what? This is oval window. This stapes, because of the spongy bone, oval window in stapes gets fixed. That's why it cannot move freely. That's why it causes conductive hearing loss. Otosclerosis or otospongiosis usually starts between 20 to 30 years, rare before 10 or after 40 years. So the age is 20 to 30 years. Females are affected twice as the male, except in India where males are predominant. It is usually bilateral. It is hereditary, autosomal dominant with incomplete penetrance, exacerbated by the pregnancy, menopause, trauma. So pregnancy you remember. Okay. Conductive hearing loss, bilateral, can be mixed or sensorineural in cochlear otosclerosis. So cardinal symptoms are hearing loss is there, obviously, painless, progressive. Paracusis willisii, hears better in a noisy environment. These are like females, how they are like, okay. These females, suppose just imagine one event that is going on in your home. Every females, so many females are sitting in your gathering and they are talking with each other, but you as a man standing outside and talking, gossiping about with other men about your wife. You are outside. Till then the female will hear your voice and tell you, you are doing something wrong with me, you are gossiping about me. So even in the noisy environment, the patient of otosclerosis can hear. That is paracusis willisii. Tinnitus will be there. Vertigo is very uncommon. Patient has monotonous, well modulated soft speech. Vertigo is not present, negative. Tinnitus more common in the cochlear otosclerosis. Usually otoscopy finding is normal except for the Schwartz sign, seen in 10% of the active cases. Rennie test is negative. Carhart's notch is present. Ossicular stiffness in the tympanometry, AS curve is seen. Stapedial reflex is absent. The unique sign here is a van der Hoeve syndrome. Triad of osteogenesis imperfecta, otosclerosis and blue sclera. Okay, BOO you can remember. BOO means blue sclera, otosclerosis and osteogenesis imperfecta. That is van der Hoeve phenomena syndrome. So the management medical is sodium fluoride, hastens maturity of active focus, hearing aids for those unfit for surgery. Then surgical is stapedectomy or a stapedotomy with placement of prosthesis, that is Teflon or stainless steel piston. So we have discussed about otosclerosis here and Meniere's disease here. Let's see it graphically. Okay. So here is otosclerosis, here is Meniere's disease. First we have discussed Meniere's disease, right? So that's why just concentrate on here, just pictorially, just remember. Pathology is flooded labyrinth. That this way you can remember this diagram. If you remember, then you will remember about the Meniere's disease. The classic symptom profile is triad of episodic vertigo is there. This is screaming, right? So vertigo is there. Fluctuating hearing loss, oral fullness is there. This is full filled by the endolymphatic fluid, so that's why fullness is there. Visual memory hook, that is you can remember by roaring water balloon, so this way you can remember, or otherwise men, as we have discussed, that way also you can remember. Diagnostic management highlights are audiometry rising curve, okay, low frequency sensory neural hearing loss, tuning fork test positive, Rene positive. Definitive treatment is salt restriction and potential stunt surgery. 35 to 60 years, males is more common. Fluctuating sensory neural hearing loss, oral fullness is there, recruitment positive is there, glycerol test is positive in the Meniere's disease. Now coming to the otosclerosis, here you can remember it as a frozen bone, painless progressive hearing loss, which is a bilateral. Visual memory, that is Schwartz sign, you can remember by this pink flamingo, Schwartz sign, okay. Diagnostic, there is a Kerhart's notch at 2000 Hertz, that is Kerhart's notch. Renes test is negative. Definitive treatment is stapedectomy or stapedotomy. So you just see this whole graphical representation, you just remember where was what. If you can recollect this visual memory, you can remember this Schwartz sign. If you can remember Schwartz, you can remember that there was something called as a Kerhart's. There were negatives this side, there were positive this side, so that way you can remember. Okay, so that's about Meniere's disease and otosclerosis.